Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. On the next several episodes, per request, I will be discussing sarcoidosis. On this episode, I will focus on cardiac and pulmonary manifestations, and then we will cover sarcoidosis manifestations in other organ systems on subsequent episodes. I will release a study guide for each episode on my website, www.theradiologyreview.com. So make sure and download the study guide for cardiac and chest manifestations of sarcoidosis on my website. Let's get into it. First, one quick statement on sarcoidosis. Sarcoidosis is a multisystemic disease with non-caseating granulomas. That's a pathologic hallmark of sarcoidosis, but the granulomas themselves are not specific for sarcoidosis, per my understanding. But if you have the appropriate clinical presentation and pathology shows non-caseating granulomas, a diagnosis of sarcoidosis can be reached. Sarcoidosis is an idiopathic disease that is thought to be inhalational, although the antigen is unknown at this time, and both sarcoid and tuberculosis are inhaled first, and then they travel from the lymphatics to other sites of the body. So with that said, let's get into cardiac sarcoidosis. About 5% of sarcoidosis cases will have cardiac involvement. If you do have cardiac involvement, that increases mortality risk. And what that means is it is important for us as medical imagers to diagnose cardiac involvement of sarcoidosis as early as possible. So, what are some typical imaging manifestations of sarcoidosis on cardiac MRI? I have not discussed much about cardiac MRI to this point, but I do want to emphasize that cardiac MRI is very important to know for the ABR core exam. I will try to focus on more cardiac MRI topics in the future. I've had several requests to cover more cardiac radiology, and by covering cardiac sarcoidosis, I hopefully will satisfy many requests I've had from listeners to both cover sarcoidosis and cardiac radiology. So here we go. Typical imaging manifestations of sarcoidosis on cardiac MRI. What are these? And whenever I ask questions, feel free to hit the pause button and think about them if you need more time. But for sake of brevity on the podcast, I will ask the question and give you just a few seconds before I proceed into the answer, as I have done on prior episodes. But just a reminder, the pause button is there if you need it. Cardiac MRI manifestations of sarcoidosis include increased myocardial T2 signal with delayed gadolinium enhancement in the mid or epicardial portions of the left ventricular myocardial wall in a non-coronary distribution. Remember that cardiac sarcoidosis rarely involves the right ventricle or the papillary muscles, and cardiac sarcoid granulomas can also cause myocardial aneurysms as well. So a little bit to unpack there. Let's go through one by one again. Cardiac sarcoidosis, you expect increased myocardial T2 signal, and the enhancement pattern on cardiac MRI is one thing that's really important. And another thing that's really important is which portions of the wall are showing enhancement. So both type of enhancement and location of enhancement within the cardiac wall are necessary things you need to understand in order to arrive at the correct diagnosis. So for sarcoidosis, you can see delayed gadolinium enhancement, and the location is the mid or epicardial portion of the left ventricular myocardial wall in a non-coronary distribution. For all cardiac imaging, you need to be really solid on the cardiac coronary distribution. So go look up the coronary distributions of the left ventricular wall so that you have this down and know it. I'll also cover this more on further episodes. With cardiac sarcoidosis, this is really a left ventricular predominant disease. It rarely involves the right ventricle or the papillary muscles, and in some cases, cardiac sarcoid granulomas can end up causing myocardial aneurysms, so be ready for that if you see an appropriate image, especially if they give you other clinical or imaging findings of sarcoidosis, because sarcoidosis is typically a multisystemic disease. Delayed enhancement of sarcoidosis can be in any location of the left ventricular wall, although it is most common in the mid or epicardial portions, and sometimes can also appear to be diffuse, patchy, nodular, or linear. However, and this is what I would really remember for board exams because they will tend to ask you the most common presentations of things like cardiac sarcoidosis. So most commonly, cardiac sarcoidosis will show enhancement in the mid-myocardial or subepicardial regions. Remember that sarcoidosis typically spares the subendocardium, and within the myocardial wall, although any portion can be involved, it typically involves the septum and lateral wall, and it can also involve the basal heart. And the myocardium may also appear thickened where cardiac sarcoidosis is present. Now, imaging can be highly suggestive of cardiac sarcoidosis, but how do we reach a definitive diagnosis? Can you think of what we could do or recommend to reach a definitive diagnosis of cardiac sarcoidosis? And the answer I'm looking for is that we need some sort of pathology to confirm sarcoidosis, and in this case, you would do an endomyocardial biopsy. And if you see those non-caseating granulomas, you would confirm sarcoidosis. If biopsy is negative, that doesn't necessarily mean it's not sarcoidosis, but you do biopsy to see if you can identify those granulomas and confirm the disease. What are some symptoms that a patient with cardiac sarcoidosis may have? Think about that for a moment. A few things you can think about are, first of all, arrhythmias. And don't forget that there is a risk of sudden cardiac death from arrhythmias that can include heart block. You can have cardiac dysfunction causing some heart failure. And in some cases, you may actually have chest pain. Let's talk quickly about manifestations of sarcoidosis on other imaging studies, although I do feel that for the ABR core exam, knowing these imaging manifestations of sarcoidosis on MRI will be highest yield. On CT, you would mostly be looking for extracardiac manifestations that we'll talk about, but in some cases, the heart could look enlarged, or you might see one of the ventricular aneurysms. And I've read that myocardial thinning can also be a sign, although as I already said, sarcoidosis can also show focal areas of myocardial thickening. So the take home from this is I think they will probably not ask you cardiac CT sarcoidosis questions. Now, what about nuclear medicine? And the main exam that you would perform for nuclear medicine diagnosis of sarcoidosis is an Fdg-Pet. And that would be a dedicated cardiac Fdg-Pet. And active sarcoidosis, you look for increased myocardial uptake. So you do some maneuvers to decrease the normal uptake or the variable uptake you can often see with Fdg-Pet, so that really there should be very little uptake. And if you have sarcoidosis, the inflammation from that sarcoidosis will take up the FDG despite the patient preparation that should knock down the cardiac FDG uptake, and you will see areas of uptake in the areas of active cardiac sarcoidosis. To be brief here, to prepare for an Fdg-Pet CT of the heart for sarcoidosis evaluation, patients are basically told that they need to have a high-fat, low-carbohydrate diet the day before the scan, and they may fast overnight. And when you fast, the heart will predominantly use free fatty acids instead of glucose. And so you are shifting the myocardium to fatty acid metabolism. In some cases, you could administer IV heparin, which also may suppress myocardial glucose uptake. So be aware of that. And if the patient has followed instructions, you hope that the normal myocardial uptake will be low. and only portions that would be involved with sarcoidosis would therefore take up the FDG. Also remember that before you do a cardiac sarcoidosis scan, it can be really helpful to have myocardial perfusion imaging, and the comparison of myocardial perfusion imaging and the Fdg-Pet can really help characterize the cardiac sarcoidosis involvement. Let's move on to the next question. What are common entities that can cause epicardial delayed enhancement on MRI? And this is important to know what the differential diagnosis is if you do see epicardial delayed enhancement. And the three things I would remember at the top of the list are sarcoidosis, myocarditis, and Chagas disease. Epicardial delayed enhancement on MRI, think sarcoidosis, myocarditis, and Chagas disease. Now, what about a differential diagnosis if you see delayed enhancement of the mid-myocardial wall? Take a moment to think of that. Tell me a few entities that can cause delayed enhancement of the mid-myocardial wall. And the top three, I think, are amyloidosis, sarcoidosis, and hypertrophic cardiomyopathy. We can get into more details on amyloidosis and hypertrophic cardiomyopathy on a later episode. Next question. What are common entities that can cause subendocardial delayed enhancement? In this case, I hope you do not say sarcoidosis because it is less common there. What are common entities that cause subendocardial delayed enhancement? And at the top of the list, I think you should keep in mind myocardial infarction with scarring, and you would expect that to manifest in a vascular distribution, obviously, or amyloidosis if you see a non-vascular or diffuse distribution of the subendocardial delayed enhancement. Next question. Can you have cardiac sarcoidosis without lung involvement of sarcoidosis? Is it possible to have isolated cardiac sarcoidosis if the lungs are not first involved? The answer is yes. However, if you see mediastinal and hilar adenopathy and you see characteristic myocardial delayed enhancement, I would assume that this is sarcoidosis until proven otherwise for board exams. And I would remember this phrase, hilar plus heart equals sarcoid. If they are showing you the characteristic myocardial delayed enhancement, and you can also see on the images that you have a lot of mediastinal and hilar adenopathy, think sarcoidosis. Hilar plus heart equals sarcoid. Can cardiac sarcoidosis cause a restrictive cardiomyopathy? One answer in general for sarcoidosis is that if they ask you anything about whether sarcoidosis can do something, just choose yes and you'll be right most of the time. So sarcoidosis can cause a restrictive cardiomyopathy, and the differential for restrictive cardiomyopathy includes sarcoidosis, as well as amyloidosis, Loeffler's eosinophilic endocarditis, that's LOEFFLERS, hemochromatosis, and other things, but those are some of the top things I would remember for board exams. Next, how can one differentiate between cardiac sarcoidosis and myocarditis on cardiac MRI? One thing that you should keep in mind is that cardiac sarcoidosis and myocarditis can look identical on cardiac MRI, so the best way to differentiate them is by presence of coexistence lymphadenopathy and lung disease, which would be characteristic of sarcoidosis. Remember, hilar plus heart equals sarcoidosis, and patient history. If you see coexistent lymphadenopathy and lung disease, you're going to think sarcoidosis on the core exam. If you don't see any of these, then remember that the differential includes sarcoidosis and myocarditis. And if there are other clues to myocarditis, that is what you would select. That is a brief overview of what I consider some of the most high-yield topics for cardiac sarcoidosis. Let's move on to pulmonary sarcoidosis. Sarcoidosis typically presents with what type of pulmonary nodule pattern? Is it perilymphatic? Is it random? Or is it centrilobular? Which type of pulmonary nodules will you see with sarcoidosis? Perilymphatic, random, or centrilobular? The answer is that sarcoid typically presents with perilymphatic nodules. Next question. What are typical early and late imaging characteristics of pulmonary sarcoidosis? Let's break this down and let's start with early. I think you should be telling yourself in your mind that you expect upper lobe predominant perilymphatic nodules. Also, I hope you remember the Lambda sign, Lambda, Lambda sign of mediastinal and hilar lymphadenopathy. This is commonly described as a 1, 2, 3 pattern. And what this is bilateral hilar and right paratracheal lymphadenopathy. What are some late findings of pulmonary sarcoidosis? And I have covered this already on my episode on lung diseases by distribution, and I believe it would be in the upper lobe predominant lung diseases. So if you haven't heard that or if you forgot, go back and take another listen to that episode on upper lobe predominant lung diseases. Late manifestations of pulmonary sarcoidosis include upper lobe fibrosis, traction bronchiectasis, and pulmonary massive fibrosis. Next, does end-stage pulmonary sarcoidosis present with honeycombing? If you see a chest CT and there is obvious honeycombing on your examination, should you think of sarcoidosis? The answer is classically no. Pulmonary sarcoidosis tends not to have as much honeycombing as other entities. Classic sarcoid is lack of honeycombing despite end-stage lung disease elsewhere. Next, what superimposed disease process can form in patients with end-stage pulmonary sarcoidosis? Can you think of any superimposed diseases or complications that patients with end-stage sarcoidosis can have? The answer I'm looking for is aspergillomas. Aspergillomas can commonly form in cavities in the lungs of patients with end-stage sarcoidosis. Now, if you see aspergillomas, that does not confirm that the superimposed process is sarcoidosis, but remember that a risk of end-stage sarcoidosis is that patients can develop aspergillomas. Next question. Besides CT imaging or chest radiographs, the Lambda sign can also be shown on what type of nuclear medicine scan? And what I am looking for is a Gallium-67 scan. With Gallium-67, you can see uptake in the bilateral hilar and right paratracheal lymph nodes that are classic for the Lambda sign. And I would remember that the degree of gallium scan uptake correlates with disease activity and severity. So the more severe or avid the uptake, the more severe or active the sarcoidosis. Next question. What is another sign on a gallium scan that is extrapulmonary that is classic for sarcoidosis? I thought we'd cover this here since I mentioned gallium scans. So I already told you gallium can show you the Lambda sign. What is another sign on a gallium scan that should make you think of sarcoidosis if they show this to you? And what I'm getting at is that you can see uptake in the lacrimal glands, nasopharynx, and parotid glands. And this looks like the eyes, ears, and nose of which animal? And if you haven't got this yet, you probably won't. And what I'm talking about is the panda sign, because it's thought that this looks like the panda's face. If that is new to you, you need to look it up. Don't wait till tomorrow. Look it up today. Look up panda sign, nuclear medicine gallium scan, and you'll see examples. So this is uptake again in the lacrimal glands, nasopharynx, and parotid glands. So both the panda sign and Lambda sign are signs of sarcoidosis on a gallium scan in nuclear medicine. Next question. What is the CT galaxy sign of pulmonary sarcoidosis? I think this is a little bit harder, but it's potentially fair game. So let's talk about the CT galaxy sign. And what that is upper lobe predominant masses with satellite perilymphatic nodules. I suppose the upper lobe predominant masses are sort of like the center of the galaxy, and the peripheral perilymphatic satellite nodules are like the little stars coming off. This happens because the nodules can conglomerate into masses or coalesce into masses, so you end up with masses with satellite perilymphatic nodules, and that has been termed the CT galaxy sign. Next question. What are some typical age and demographic characteristics that you would expect for sarcoidosis on a board exam? And this is true for any organ system that may be involved with sarcoidosis. You need to know the typical age and demographic characteristics that, if presented to you on a board exam, should raise suspicion in your mind that sarcoidosis could be present. And the age is a 20 to 40-year-old person. I think that's pretty good to remember. So 20 to 40-year-olds, and most classically an African-American female, but definitely not exclusively. If they give you a history of a 20 to 40-year-old-ish person, and if they provide additional history that the person is an African-American, especially an African-American woman, you should be cued in that sarcoidosis might be something that they will ask you about. And I would remember that most sarcoid patients become symptomatic prior to 40 years old. So initial diagnosis will typically require some form of advanced imaging in a patient under 40 years old because symptoms have developed. What organ is most commonly affected in sarcoidosis? I think this is important to remember. I also suspect most of you will get this. And for an extra clue, I told you that we are now talking about pulmonary sarcoidosis, and the answer is the lungs. Next question. What are some laboratory values that are typical of pulmonary sarcoidosis? And I would look for these in your history. And what you are looking for are elevated ACE levels, ACE, or hypercalcemia, or probably both. So in a clinical stem, if you see anything about elevated ACE levels in a 20 to 40-year-old person with hypercalcemia, they're really trying to give you clues about sarcoidosis here. So keep that in mind. How many stages of pulmonary sarcoid are there? This is a little tricky, and I'll tell you why, but how many stages of pulmonary sarcoid are there? The answer I would remember for board exams are 4 stages that include stage 0. So if you count on your fingers, that will get you to 5 because 0 is a stage. But there are stages 0 to 4. And these are typically, most classically on a board exam, going to be staged or asked based on chest x-ray findings. And I want to run through those. What are pulmonary imaging manifestations for each stage on a chest x-ray? Let's start with stage 0. How does stage 0 pulmonary sarcoidosis look on a chest x-ray? The answer is normal. You do not see any chest x-ray imaging findings at stage 0. What will you see with stage 1? What you need to remember are hilar and mediastinal lymph nodes present with stage 1 disease. If you're seeing a lot going on in the lungs, this is now beyond stage 1. So stage 1, hilar mediastinal lymph nodes only, and 50% of cases will present as stage 1. So most of them will be here. No lung findings on an x-ray, but you can see the central adenopathy, bilateral hilar, and mediastinal region. Stage 2 looks like what? Well, first of all, you will have pulmonary parenchymal disease, and then you will also have the hilar and mediastinal nodal disease, and 30% of patients will present here. So between stage 1 and stage 2, that gives you about 80% of patients. And what I would assume from this is that because 80% of patients present with stage 1 or stage 2, it's probably also most likely that a board exam question would ask you about stage 1 or stage 2 disease on a chest radiograph. Let's move on to stage 3. And this one is hard for me to remember because, why? Read my mind, but this is hard for me to remember because I forget that the lymph nodes can burn out in sarcoidosis. So stage 3 is only parenchymal disease because the nodes have burned out and are no longer enlarged on chest radiograph. Stage 1 is only hilar and mediastinal nodes. Stage 3 is only parenchymal disease with no nodes, and stage 2 is both. Now, stage 4 is the easiest to remember, other than perhaps stage 0 that's normal, because stage 4 is just end-stage pulmonary fibrosis, and you're going to see a lot going on. And this is also termed progressive massive fibrosis, which, as a reminder, other causes of progressive massive fibrosis include silicosis and tuberculosis. With stage 4, I would expect that the lungs will look really bad if they are asking you that on a board examination. What is the treatment for end-stage pulmonary sarcoidosis? Let's say that a patient does progress to stage 4 disease. What are your treatment options? And for board examination purposes, I would remember that pulmonary transplant is the primary treatment for end-stage pulmonary fibrosis / progressive massive fibrosis from sarcoidosis. Next, can sarcoidosis recur after pulmonary transplantation? And I already told you that if they ask you any question about whether sarcoidosis can do just about anything, the answer is yes. And in this case, it is also a yes. Pulmonary sarcoidosis can recur after pulmonary transplant, unfortunately. And sarcoid is perhaps the most common disease that can recur after pulmonary transplantation and may happen in up to 35% or so of cases, based on what I've read. Next question. Is sarcoidosis on the differential for fibrosing mediastinitis? Remember the rule I've already told you. If they ask you any question on whether sarcoidosis can do something like cause fibrosing mediastinus, your answer is yes. So although histoplasmosis is the most classic cause of fibrosing mediastinitis, other causes include sarcoidosis, tuberculosis, and radiation. So most classic for fibrosing mediastinitis, remember histoplasmosis. However, differential includes sarcoidosis, tuberculosis, and prior mediastinal radiation. Let's get through a few more questions and then we'll conclude for this episode. Does pulmonary sarcoidosis typically have uptake on Fdg-Pet CT? I think this is an easy question because the answer is yes, and I've already told you that the cardiac sarcoid takes up the FDG. So by extension, you can assume that the pulmonary sarcoid will as well. The inflammation from the sarcoidosis causes FDG uptake and is a cause of a false positive FDG scan in the lungs, as well as other infectious and inflammatory processes to include tuberculosis, fungal infections, pneumonia from various sources, rheumatoid nodules, and so forth. So you can see uptake in pulmonary sarcoidosis on a PET scan with FDG. Can sarcoidosis cause tracheal thickening? Knee-jerk reaction should probably be yes at this point, and the answer is yes. But now the harder question. Is sarcoidosis tracheal thickening typically of the circumferential type or of the cartilaginous type? This differentiation between the types of tracheal thickening deserves its own episode, which will eventually come. But which type, circumferential or cartilaginous, do you expect with sarcoidosis? The answer is that sarcoidosis presents with the circumferential type of tracheal thickening. Now, if you see circumferential tracheal thickening with lymphadenopathy and upper lobe predominant perilymphatic nodules, what are you going to answer? If you don't get this question right, you need to restart this episode and listen again. Okay, they're giving you circumferential tracheal thickening, upper lobe predominant perilymphatic nodules, and mediastinal or bilateral hilar lymphadenopathy. You are going to select sarcoidosis, and you would probably be correct if you did that. The differential diagnosis, just to cover quickly, of circumferential tracheal thickening, and this may not be inclusive, but it includes amyloidosis, And with amyloidosis, you would expect bulky calcified nodules and or cysts in the lungs with nodular septal thickening in the lungs. Differential diagnosis of circumferential tracheal thickening also includes granulomatosis with polyangiitis, and with that you would expect cavitary pulmonary nodules with pulmonary hemorrhage. Tuberculosis and inflammatory bowel disease is also on the differential of circumferential tracheal thickening. Last question for this episode. What is the association of sarcoidosis with cigarette smoking? The answer is that cigarette smoking actually decreases the incidence of sarcoidosis. The other entity I would keep in mind that is actually lessened by cigarette smoking is hypersensitivity pneumonitis, and I've mentioned that on a prior episode as well, lung diseases by distribution. So cigarette smoking actually decreases the incidence of sarcoidosis and hypersensitivity pneumonitis. Nonetheless, don't go out and start smoking. And in my mind, at least, I think the reason why is that the cigarette smoking damages the normal immune response that you would expect in the lung, so you can't form the caseating granulomas or the centrilobular nodules of hypersensitivity pneumonitis that you normally would. I hope this episode was helpful. Remember, go to my website, theradiologyreview.com, and download the study guide for this episode. I will continue discussion of sarcoidosis and other organ systems on the next episode. If you have other requests you would like me to discuss, please let me know. Please share this podcast with your friends. We're starting to get into real crunch time for studying in coming months. And I think listening to this podcast now can get you set in the right direction for really heavy board study in coming months. Thanks to each of you who have followed me on Twitter, and remember to prepare to succeed and to study really hard for your radiology board exams because it requires your best effort. That's all for now. I'll catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.